In the 1920s, Reich observed that individuals with rigid character defenses, character armor, also had muscular hypertrophy and rigidity. When the patient's character defenses yield to character analysis, the approach Reich developed to dissolve character armor, the chronic muscular rigidity also softened. With a particular patient with a stiff-necked attitude, when his characteristic defense finally let go, the patient experienced a spontaneous, dramatic, autonomic physical reaction of his face.
Hi, I'm Dr. Chris Burrett. Welcome to the ACO's A Different Kind of Psychiatry Case Presentation webinar. We're glad to have you. I'm happy to introduce our speaker today, Dr. Howard Chavis, who will be presenting Emotional Energetic Contact, Essential for Effective Treatment.
Hello?
Welcome, Dr. Chavis. It's good to have
Thank
you.
you. Hello.
Dr. Chavis is in private practice in psychiatry in Manhattan and Scarsdale, New York. He is board certified in psychiatry and medical orgonomy. He received his MD degree from the Albert Einstein College of Medicine, and he completed his psychiatric residency at Jacobi Hospital in Bronx, New York. He's a member of the American College of Orgonomy and editor of the Journal of Orgonomy. And before we start, so everyone knows, you can type in questions into the Q&A section, and we'll get to those at the end. So, Dr. Chavis, how did you decide to present this topic?
I love my work. And at the heart of what I do and how I help my patients is emotional energetic contact.
Wonderful. Let's hear it.
Hello, everyone, wherever you're zooming in from. I'd like to thank the American College of Orgonomy for affording me the opportunity to talk about emotional energetic contact, essential for effective therapy. And my thanks to you, Dr. Burrett, for being the host. In my presentation, I'm going to be talking about natural science, which is the study and knowledge of objects and processes observable in nature. This includes all aspects of human functioning. I'm going to briefly describe how Wilhelm Reich came to develop medical orgone therapy. This will allow us to see ourselves in a natural scientific perspective. That is, from the perspective of how nature functions. Reich referred to this way of thinking as functional thinking. This, by the way, is distinct from today's pervasive mechanistic thinking, which in the realm of technology and machines is completely rational. In the realm of the living, not at all. Wilhelm Reich, a physician, Wilhelm Reich, a physician and a student and colleague of Sigmund Freud in the 1920s and early 1930s, developed medical orgone therapy, a unique therapy which addresses and dissolves chronic defensive rigidity in both the patient's character, the characteristic way the individual lives in the world, and in their musculature. Orgone is the name Reich gave to the mass-free energy he discovered in his laboratory research in the middle part of the 1930s, in the atmosphere in 1940, and which he scientifically investigated until his death in 1957. Orgonomy is the science of orgone energy, which includes medical orgonomy, social orgonomy, orgone biology, orgone physics, and so on. First, I'd like you to look at the following brief videotape segment of a living amoeba seen through the microscope, magnified 800 times. Chris? So what do we see that is common to all of nature? Spontaneous movement, expansion, contraction, pulsation. Thanks, Chris. Now, if we think of expansion in terms of the weather, what constitutes expansion? An expansive day. And how do people feel on such a day? It's sunny and you generally feel positive, energetic, and outgoing. Conversely, what constitutes contraction? A contractive day. And how do you feel on such a day? It's cloudy, overcast, rainy, and people generally feel less outgoing, sometimes low. And how do you feel when you see your child take a first step? Or you reach out to hold your mate, whom you haven't seen for a long time? Conversely, how do you feel and where do you feel it when the car you're driving in begins to slide on ice or a wet road? Or you see flashing red lights in your rearview mirror. What I'm describing by way of your own emotions and sensations is that the human organism expands and contracts, it pulsates, and that this pulsation is a biological phenomenon. It is not a poetic metaphor. In a series of experiments with human subjects, Reich demonstrated that the subjective experience of pleasure and anxiety could be measured objectively. Using the technology of the day, in 1934, a vacuum tube amplifier and an oscillograph, Reich demonstrated what he called the basic antithesis of vegetative life. That is, that pleasure and anxiety are literally opposite feelings. In other words, in pleasure, something, which he later discovered to be orgone energy, moves out to the skin surface towards the world. And in anxiety, something moves away from the skin, away from the world, toward the core of the body. Just for emphasis, let me point out that if today you ask most, if not all, doctors and psychiatrists, or anyone for that matter, what actually emotion is, chances are you won't get the simple reality discovered by Reich, that emotion is the perception of energy flow and movement in the body. Utilizing his experimental observations and the research of Krauss and Zondek, he discovered that pleasure is functionally identical to excitation of the parasympathetic branch of the autonomic nervous system and anxiety to excitation of the sympathetic branch. The meaning of this in terms of the vegetative antithesis is clear. The anatomic activities of the biosystem, contraction at the periphery and dilatation of the organs in the core of the body, is consistent with movement away from the world. With parasympathetic excitation or expansion, these functions are exactly opposite. There is movement toward the world. This is the mechanism that anchors pulsation in the human body. At this point, you may be thinking, how did Reich, a psychoanalyst, come to focus on excitation, expansion, and contraction, on biological pulsation? We know from his own written description that he had always been interested in the energy process, and that this for him received priority over substance or matter. As a medical student, he was drawn to Freud and psychoanalysis because of Freud's psychic energy concept of libido and his discovery of infantile and childhood sexuality, the psychosexual stages of development. Early in his analytic work, Reich searched for the emotional intensity so often absent in his patients led to his discovery that feelings, emotions, were bound up in and by rigid character reactions and structure, what he called character armor. This was the first time that the character, the chronic characteristic way an individual interacts with the world, was identified as defensive. He pointed out that in our neurotic world, character in general and specific character types in particular, such as the hysteric, the phallic narcissist, the obsessive compulsive, are formed in everyone according to certain determinants, but always as a result of a traumatic conflict between the infant and child's individual spontaneous expressions, their natural impulses, and the limitations imposed by the environment, usually the parents. Although there may be cultural differences worldwide in child-rearing practices, this is still universally true. Although its original function is positive, protection, there is a cost to this armor. No matter the individual's character, characteristic attitudes, or traits, there is a decrease in emotional motility and liveliness, a decrease in the ability to open oneself up to or close up to experience. In the 1920s, Reich observed that individuals with rigid character defenses, character armor, also had muscular hypertrophy and rigidity. When the patient's character defenses yield to character analysis, the approach Reich developed to dissolve character armor, the chronic muscular rigidity also softened. With a particular patient with a stiff-necked attitude, when his characteristic defense finally let go, the patient experienced a spontaneous, dramatic, autonomic physical reaction of his face. This is how Reich came to discover muscular armor and its function, which led him to work directly on patients' chronically tense musculature. Muscular armor is a natural biological defense. It is sometimes even seen in newborns. And in fact, we all tense up in stressful situations and hold our breath, but we then relax and let go when the situation passes. When muscular armoring becomes chronic, however, it interferes with natural, emotional, and physical motility, and depending on its severity and distribution, it also can interfere with natural physiologic processes and can lead to physical disease. Wright described the anatomical distribution of human skeletal musculature as segments arranged perpendicular to the long axis of the body, much like the angular segments of a snake or worm. Chris, as shown in the following diagram, there are 7 segments: ocular, oral, cervical, thoracic, diaphragmatic, abdominal, and pelvic. Clinical experience, uh, thanks, Chris. Clinical experience reveals that muscular armoring is laid down in these segments in a functional distribution. This means, for example, when the newborn spontaneously instinctually reaches out with its eyes to its mother, part of the natural process of newborn maternal bonding, and it sees anxiety, coldness, or even hatred, it will pull back and contract, especially in the ocular segment, the eyes, the scalp, the occiput, and even in the brain if the trauma is severe enough. For the medical orgonomist, ocular armor is observable even in the newborn. Another example, if the child is not allowed to speak, if it is verbally or even non-verbally somehow told to be quiet, to keep quiet, it must hold back the impulse and does so with tension in the throat, mouth, neck, and upper thorax. If breastfeeding is stopped prematurely, or if it is accompanied by significant enough maternal anxiety or disgust, the infant may armor in the mouth with tension in the masseters, the extraoral musculature in the back of the neck. Premature toilet training before the infant has developed natural control of the anal sphincter. And I want to point out that this control will develop spontaneously in every human infant. It can only succeed, toilet training can only succeed through contraction of the muscles of the pelvic floor, the buttocks and thighs, aided by retraction of the pelvis and inhibition of respiration. And so muscular armor is laid down layer upon layer during the child's development and is the somatic physical basis of armored character formation and the armored character itself. Thus, what I've described is that armored parents, in direct proportion to the distribution and severity of their own chronic armoring, create armored babies and infants and children. This accounts for how our sweet babies and children become, to one degree or another, complicated, difficult adults. Let me also point out here that permissive parenting, often thought of as a positive answer to suppression of the infant and child, is often even more destructive because the parents may be even more out of touch, clueless with the emotional needs of their youngster. Because it blocks movement of sensation and emotion, arming always interferes with the individual's ability to make contact with themselves, with others, and with the world. Contact, the quality, you might say, of being there, being in the moment, the ability to make and sustain an emotional, energetic connection, is determined by the capacity to tolerate intensities of sensation. Here, I'd like to point out the importance of energetic emotional contact, essential to the treatment of patients, requiring the therapist as well to be able to tolerate intensities of emotion and sensation. This is why acceptance into the training programs of the American College of Orgonomy requires the candidate to have had their own medical orgone therapy, even if it is ongoing. It is known that patients want to feel and be understood, that the therapist gets them. Emotional energetic contact is not only real, but it is palpable. It is not a psychological concept. It's not mystical. It is an actual energetic reaching out. It is the opposite of therapeutic analytic neutrality, constraint or withdrawal. And most importantly, it is perceived by the patient as acceptance. I repeat, it is perceived by the patient as acceptance. Thus, there are 2 different kinds of individuals: the unarmored, in the real world, those without significant armor, and those with armor. The structure of the individual without significant armoring is graphically portrayed. Chris, you have the slide. It shows the three layers of the unarmored human emotional structure. Of course, not to worry. There's no quiz or exam following my talk. Also, you don't have to see specifically the details, but the overall view that the unarmored individual is simple and that the armored individual is complicated. So we see, excuse me. So what we see is the unarmored human bioemotional structure. The biological core is the home of our individual nature, what we're born with, the source of our healthy primary impulses, what we see in infants and children. The biological core is real. It's not imaginary, poetic, or psychological. It is comprised of the autonomic nervous system from which biological excitation arises. The social layer is that part of our structure which interfaces with the world. In health, this layer is in more or less direct contact with the biological core. The middle layer contains the armor, which in health is transitory. We defend and hold back feelings when necessary, but then let go. Such an individual is uncomplicated. Rare, to be sure, but there actually are such individuals. When armor becomes chronic, however, the social aspect becomes a social veneer or facade, which is separated from the biological core by the secondary or great middle layer. This is graphically portrayed in the following diagram. Chris, armored human bioemotional structure, please. The great middle layer is the repository of the harsh, destructive secondary impulses, which form as the result of the frustration and distortion of core impulses as they try to break through the armor. Chronic armoring is the source of human destructiveness, of human evil. Reich referred to this middle layer as the realm of the devil. The social facade then has a defensive function. Its sociability and rules protect against expression of these destructive secondary impulses. From these two diagrams, we can clearly see the logical goal of therapy. It is to remove the restrictions to the free flow of energy throughout the body, to restore the individual's capacity for natural bioemotional, bioenergetic pulsation. In practical terms, the goal is to dissolve sufficient chronic characterological and muscular armor and restore the individual's capacity for making and sustaining emotional energetic contact. In other words, to restore our capacity to be spontaneous and free-flowing like the amoeba when external circumstances allow. Now, I will point out that emotional energetic contact is possible for anyone, but especially those who are not significantly hampered or constrained by armor. A patient recently saw Emmanuel Axe in concert and had seats very close to him at the piano. With intensity and obvious excitement, she said, "He was one with the music, with the piano. I've never experienced anything like it." Emotional, energetic contact for the pianist and for my patient. Years and years ago, I attended the Hampton Classic Horse Show. I had a great seat and saw the American Olympic men's equestrian champion complete the course. He was one with the horse. Beyond words, this was palpable and unforgettable. Emotional, energetic contact. Every other rider, male and female, highly experienced, to some degree, even to a small degree, was trying. What a difference. I went to a professional golf tournament in New Jersey. It was the third round and the crowds were modest. I found myself on a par 4 hole, standing alone about 150 feet from Arnold Palmer, who was on the right side of the fairway. If you're a golfer, you know who I'm referring to, one of the golfing greats. We took each other in. No words were spoken. Time literally didn't exist. Profound emotional, energetic contact out of the blue. Given this experience, it was obvious why everyone loved him. I invited a Mount Sinai friend, Leon Deligdish, to view a Reich blood test at the ACO laboratory in Princeton, New Jersey. Dr. Deligdish, a world-renowned pathologist, researcher, and discoverer, lecturer, and author, sat down at our Zeiss research microscope and expressed amazement. Why? The right blood test involves looking at living blood in warm physiological saline straight from the finger of the test subject. She was almost speechless because in her many decades as a clinician and researcher, looking through the microscope, believe it or not, she had never once looked at a living specimen. All were fixed, stained, and dead. This in contrast to living red blood cells that move and pulsate. I mention her in this context because when she sat down and looked through the microscope, I saw her simply let go. Her body visibly let go. She allowed the field in view to come to her. Emotional, energetic contact. I had never seen this in our laboratory before or since. Now here, believe it or not, I'll mention Bach and Beethoven, who when asked replied that their music came straight from God. Mozart, on the other hand, said, "From where it comes, I know not." Profound, emotional, energetic contact. Someone learning that Mozart heard his compositions fully formed said, "That's a miracle." Mozart replied, "That's not the miracle. The miracle is that I remember it all so I can then write it down." Again, emotional, energetic contact. There are three basic tools the medical ergonomist uses in this work. Undoubtedly, training and clinical experience are certainly important. However, emotional, energetic contact is crucial. Emotional, energetic contact allows the ergonomist to perceive and feel what is occurring in the moment, in the patient and in him or herself. Reich pointed out in character analysis that the therapist often doesn't have to think of what to say, it just happens spontaneously. I can certainly attest to that. Sometimes in the patient's that I will describe, this may not be obvious, even though it is always at play. Other times it will be. The first tool in treatments is to have the patient breathe fully, but not in a forced or mechanical fashion. This builds up or excites the individual's energy charge, which in turn exerts a push against the muscular armor. Some holding then often yields with the spontaneous release of crying, anger, fear, or other emotions. A patient came to me saying, "I need to cry, but I can't." She felt frustrated, anxious, and blocked. Her previous several years of talk therapy had been unable to help her. With her sitting up, I saw that she had significant holding in her chest, which appeared immobile, and some holding in her face. I asked her to lay down on the couch on her back and had her breathe and move her face. After a few minutes, she began to cry, first without sound, then with sobbing from deep within her chest. This continued for about 10 to 15 minutes. She told me then she felt deeply sad, although she didn't know why. She also said, "I felt relief." In full, energetic, emotional contact, I said nothing. This was her very first session. Another patient in his early 30s who I had seen from many previous sessions lay on the couch and started breathing as I had recommended. He soon began to spontaneously cry and then let out the most god-awful frightening sounds and thrashed about on the couch. This lasted for many, many minutes. He then quieted down and after several more minutes told me he had just re-experienced the terrible beatings his mother gave him when he was only 7 years old. Another tool employed by the medical ergonomist is direct work on the patient's spastic tense musculature. The general principle is simple. Pressing on a tense muscle causes it to contract. Continued pressure causes continued contraction and ultimately fatigue of that muscle. It lets go, and whatever emotion was held back by the tense muscle is released. If there's a discrete experience, such as a specific traumatic event associated with the held back emotion, the individual will often relive the experience on the couch, complete with the long repressed emotion. There's a feeling of great relief with this emotional release. A patient with high blood pressure was referred by his cardiologist because of depression. I talked with him for a few minutes, and he told me he was depressed but didn't know why. I could see that his chest was held high in an inspiratory attitude commonly seen in those with high blood pressure and cardiovascular disease. Over several sessions with the patient on the couch, I was able to bring his chest down by pressing on it with the flat of my hand, with gradually increasing pressure with each exhalation. With time, I encouraged him to let out any sounds and to move his face. At first indistinct, his sounds and facial expression began to reveal fear. This was gradually replaced by angry growling and yelling. With increased pressure on his chest, he was soon expressing intense rage, which lasted and lasted. Afterwards, he told me the following. 8 years before, he was on a city bus and witnessed some young toughs taunt an elderly woman and steal her pocketbook. No one said or did anything. He alone told them, "Give the woman back her pocketbook." One of the gang came toward my patient in a threatening way, reaching into a paper bag he was carrying. My patient was absolutely terrified and was convinced he'd have to fight for his life. Just then, the police arrived and arrested the toughs. There was a gun in the paper bag. My patient saw the gun. In the session, he was not telling me verbally he was afraid and angry. Relieving the muscular armor with direct physical pressure, he expressed the intense emotion he had experienced 8 years before, but which had not been expressed and released, and instead held in his chest. Another patient, a physician, came to me because he had intrusive thoughts of a passive sexual nature, which bothered him greatly, and he was very depressed. Did I prescribe antidepressant medication for him? No. I could readily see he was incredibly held back and physically tense. I put him on the couch and began to work on the superficial layers of muscular armor, his neck in particular, his occiput, the back of his head. I did not press on his chest, but what came out just by working on the back of his neck and then his jaw was yelling in anger. And it turned out how he lived, took care of his patients, his family, and others, always came first. Characteristically, at any time it had to do with him, he took a back seat, if at all. While tremendous frustration and anger built up in him, the intrusive, compulsive thoughts were of a passive nature. This reflected his characteristic attitude, how he lived. I addressed this and directly pressed on and dissolved his muscular armor. Over the course of a once-a-week, 2-year therapy, he began to introduce himself, who he really was, to his family. For example, he always wanted a particular sporty car, but never said, "I want this car." He finally spoke up and got his car. His intrusive thoughts diminished and then disappeared. Also, incredibly, over the course of his treatment, his adult onset asthma that he had for at least 15 years and that he took 3 different medications for also diminished. His medications were tapered and discontinued, and his asthma completely disappeared. This is not unusual for the medical ergonomist because we understand that physical symptoms and illness so often originate from chronic armoring, rigidity in the muscles of various segments of the body, worsened by characteristic defensive attitudes. The third tool employed by the medical ergonomist is addressing characteristic defensive attitudes. A patient lying on the couch out of anxiety often hesitated speaking. In one session, I noticed she was holding a tissue. All I said in a kindly way was, "You're holding a tissue." She looked and said, "Yes, I'm holding on." She then started to cry and began shaking all over. Another long-standing patient came into my office, and I noticed for the first time that she was shuffling her feet. Did I say to her, "You're shuffling your feet," or "Why?" No. Instead, believe it or not, I shuffled my own feet. At first she laughed, and then she started to cry. She felt victimized by the world. As we looked into this and talked about it, it turned out she was afraid to speak up for herself and had a very passive attitude in life. Shuffling my own feet led her to make contact with herself and how she lived. Another patient, successful looking, well-dressed in his early 60s, came into my office and sat in the patient's chair. He put his arm over the back of the chair. With full emotional, energetic contact, I listened to him for about 3 or 4 minutes and then asked, "Do you feel as comfortable as you look?" He just looked at me for 5 or 10 seconds and then said, "No, I do this to put you at ease so I don't feel anxious. It turned out that in the 30 plus years of therapy he had previously had with many different therapists from many different schools of therapy, no one either saw or recognized the significance of what was right in front of their eyes. And for me to sit there and listen to his history, the story of his many therapies, or anything else for that matter, would have been a complete waste of time. Instead, I addressed his, obvious to me and felt by me, his defensive attitude. A 32-year-old woman came to me unhappy and depressed, a bit angry and anxious. She told me she lived with a man who didn't treat her well, who was in fact emotionally abusive. Believe it or not, as she spoke, I saw that she smiled. I gently pointed this out to her. You're smiling. She was unaware that she smiled. Occasionally, I pointed out her smile, and she gradually became aware just how angry, even furious she was with how her boyfriend treated her. In the second session, her fear of speaking up for herself came to the fore. We discussed how she could handle the situation. In the third session, she announced she had kicked the bum out and ended the relationship. In the fourth session, she remembered that when she was a girl, her friends called her Smiley. This was her last session. She no longer needed treatment. No medication was prescribed. I was asked to see a 33-year-old Chinese woman medically hospitalized for her remarkably distended abdomen. Despite a thorough, intensive medical workup, no cause could be found for her distressing symptom. As a last resort, I was asked by her doctors to see her. I did. I identified myself as a psychiatrist and asked a few basic questions. She told me she was married, had 3 young children, and lived with her husband in New Jersey. This inexplicably prompted me to ask, spontaneously, who else lives at home with you? She responded, my mother-in-law. Believe it or not, that gave me her diagnosis. How, you ask? When she said, my mother-in-law, I saw she swallowed. This was the source of air in her stomach and her GI tract. As we discussed her mother-in-law visiting from Taiwan, I quickly learned that the woman was relentlessly controlling, cruel, and nasty to her daughter-in-law and critical of her efforts with her young children. Because of their Chinese culture and her own characteristic not speaking up for herself, the patient had to respect her elder and could not defend herself against her mother-in-law's onslaught, and she did not even tell her husband. Over several sessions, I pointed out her swallowing, her anger surfaced and was expressed more and more fully. We then met with her husband, and he expedited his brother's return to Taiwan. Case solved. With an 85-year-old patient who really hates Trump, I occasionally bring up Trump. The most recent example was a few weeks before the November election. Spontaneously and with seeming curiosity, I asked her in the session, and this is a true story. I said to her, if I asked you as my dying wish, would you donate $25 to Trump's? I'm sorry, I'm apologizing because I'm laughing. I shouldn't. If I asked you as my dying wish, would you donate $25 to Trump's election campaign? Would you? She looked at me incredulously and angrily and then replied, of course not. And she then laced into him with even more fury. Lest you think I was being sarcastic or political, trying to be funny. 30 years before she tried to kill herself and almost succeeded. She lost her dad when she was 6 years old, and her mother refused to let her cry and grieve. She became her mother's helper and developed her red thread, her main character trait being a good girl. I become the excitement, spontaneously focusing on her hostile daughter, Trump, or her ex-husband. With treatment, she now expresses her anger with real, intense anger, even using curse words, and feels so much better for it. The emotional, energetic contact between us allows me to say seemingly outrageous things to her with great therapeutic benefit. Another example, my capacity as a consultation liaison psychiatrist, seeing medically hospitalized patients, I was asked to see Rose, an 86-year-old patient in the medical special care unit, status post heart attack, to make sure she was okay. After discharge, she came to me every week for 4 years, whether rain, snow, heat, or cold, or wind. We liked each other. She told me of her romantic experiences. At age 16, she went on a blind date, and she told me, the instant I saw him, I knew he wasn't for me. He was so short, I'd have to shake out the sheets to find him. I also heard about the ups and downs of her past long-term relationship with a married man. One day in session, she was down on herself. Disparagingly, she told me, all I do is sit on the edge of the sofa, watch TV, and eat cake. At session's end, uncharacteristically, she asked, so, Dr. Chavis, what should I do? And this is what stumbled out of my mouth, literally. I said, I think you should go home and have a piece of cake. Oh my God. Spontaneous laughter from both of us. Another time she told me she was taking a shower, looked down at her almost 90-year-old body and said, ugh. I immediately, without missing a beat, said, what about your legs? Even in her late 80s, she had very attractive legs. Again, emotional energetic contact and spontaneous, seemingly outrageous comments that were extraordinarily supportive and therapeutic. I saw a patient's mother. She was around 90 and she was financially the poorest patient I ever saw. She subsisted on Social Security and a tiny pension. I offered to see her for $5 a session, but she refused. She insisted on paying me $10. At this point in her life, she was incredibly lonely and emotionally bereft. She had been widowed for at least 15 years, and she didn't miss her husband one bit. He'd been emotionally abusive and distant. In one session, she told me she missed the man's touch. She didn't have to elaborate. I stood up and stretched my arms out to her and held her in a warm embrace. Emotional energetic contact allows for seemingly non-traditional therapeutic interactions. Again, as a consultation liaison psychiatrist at Mount Sinai, I was asked to see an 18-year-old patient in the medical special care unit. He was terminally ill, and it was thought that, given his medical condition, he should have already died many days before. He had not died, and the staff wanted to know why. I stood by his bedside and introduced myself. Hello, Dan. I'm Dr. Chavis. I'm a psychiatrist. Any idea why your doctors wanted me to see you? His eyes were closed, and he never in any way acknowledged my presence. I remained standing motionless alongside him, my hands on the bed rails. I wasn't anxious. I wasn't thinking, what could I say to engage him? I simply breathed. I was emotionally, energetically present. After many minutes without opening his eyes, he asked, am I going to die? I responded with a simple yes. After many minutes, I told him I was going to leave, and I said goodbye. 2 hours later, he died. I was asked to see a patient in his early 40s, recently diagnosed with very advanced cancer. He's being aggressively treated, and despite various anti-nausea medication, he was severely nauseous. As a medical ergonomist, I knew that nausea can be a symptom of disgust or repressed, held-back crying. I introduced myself and asked him why I, a psychiatrist, was asked to see him. He didn't know, so I asked, what's going on? He told me he was diagnosed with advanced cancer and began talking about his fears for his elderly father who lived with him, if he, the patient, should die. I remained emotionally, energetically present as I sat close to him at the bedside. He very well may have felt how moved I was. Some of you might think this is mystical or my imagination at work. However, if you saw how he broke down and cried, you might think otherwise. This brings to mind the patient's account of his treatment with Reich. In a series of articles in the Journal of Orgonomy written by the patient, he described always feeling that Reich had his arm around him, like a friend. Emotional, energetic contact. I'm not comparing myself to Reich, but the reality of emotional, energetic contact and its effect on people and patients can be profound. Here I point out again that to be accepted into the ACO medical or social ergonomy training programs, either as a physician, a psychologist, a social worker, or a teacher, one has to have had medical orgone therapy. This is essential, as I hope I've demonstrated, because the therapist has to be able to tolerate emotional energetic contact and the intensities and expression of emotion that the patient and the therapist experience in treatment. Otherwise, he or she will find a way to derail the treatment, sometimes with destructive consequences. Thank you.
Thank you, Dr. Chavis.
Well,
There's a question from the audience. How did you feel about that patient, Dan, who died after you saw him?
while I was just standing there, allowing myself just to be present, meaning in full emotional energetic contact, not distracting myself or withdrawing in any way. I was incredibly moved, incredibly moved.
Yeah. I'm moved to hear about your work. It's obvious to see you and hear you talk about your patients, how much they move you,
Yes,
and how good the connection you can develop with them is.
yes,
Something that really stood out to me, um, was there wasn't a lot of talk about, information. Information can be helpful. A doctor takes a history, and, I wonder if there's something you could say about that.
yes. Again, emotional energetic contact allows me to see, observe, perceive what's going on with the patient. If I were a psychoanalyst, I might be interested in hearing more about their history, but that uh, is not necessary for me to see what's going on with the patient, to perceive them, to sense and feel what's going on, and then to know what to do with that. And fortunately, I can ask a question like, what's going on? Or, or not. Or I can just have the patient, like with this patient who came to see me who couldn't cry, even though she so desperately wanted to cry. I just asked her to lay down on the couch, and I made the observation that she had a significant enough holding in her chest barely moved, and she had some holding in her face. This might not have been obvious to anyone else. I didn't have to know what was going on with her. Um, uh, I could see what was going on with her. I didn't have to know anything more about her history. She spent years with a very competent psychologist going over this, and she didn't get what she absolutely needed, was to just breathe. And this is key because very often I'll sit there with a patient and they may talk, for 20 minutes, 15 minutes, and I might say to them, as you're talking, I see that you're barely breathing. You're certainly breathing enough to keep you vertical, but the reality is that people often hold back the depth or intensity of their breathing because that helps control or contain the intensity of whatever emotion is going on inside them. And that really is at the heart of my work because I identify for patients what they do that distracts them or is an obstacle to their being in touch with themselves. And it could be the attitude, it could be something physical. Um, uh, but that's my focus. And it's not years and years and years of treatment. I don't have to quote unquote figure out the patient.
Right, right.
They're telling me who they are and what I do with that based upon my capacity, my ability to have emotional energetic contact with them, my training and my clinical experience, that leads me in the direction of how to effectively help them.
Yes. I wonder if you have any experiences with not feeling something from someone, or not having a connection. Does anything come to mind?
Yeah, that's information. I always look and see, how come?
Yeah.
How come? I have to see, to be in touch with myself enough to see, literally, am I breathing? Is there something going on here
Mhm.
that's off-putting to me? And then I can deal with that directly.
Yes. Very good. The other thing that stood out, you mentioned 2 patients, that woman who, uh, I think said she was sad and wasn't sure why, and then there was a man who was depressed and didn't know why. What could you say about the importance of why?
Well, that's another thing. If I were a psychoanalyst, the why is paramount and primary. For me, the why is not significant initially because that will reveal itself as I effectively address what the patient, say, brings to the session. Meaning, what are they doing that interferes with their contact with themselves? And everybody has this to one degree or another. Sometimes more, sometimes less. And now, especially with the younger population, I treat, and my colleagues often treat patients of all ages, from little babies, to seniors. And, when I see a youngster, uh, especially if they're months old or a year or two old, addressing and dissolving whatever holding they have is both. It can happen very quickly. For example, treating a 2-year-old, why he has holding in his jaw and his neck, I don't know. It may relate to his birth experience in the hospital, but that's not essential. What's essential is that I dissolve the holding, I address it. Now, I don't beat up on the kid. With some adults, you have to press very hard. But with a kid, with a youngster, and especially with an infant, um, you don't have to press hard at all. And I very often I touch the mother's hand or her arm with my thumb, and I show them exactly how little pressure I'm exerting. And lo and behold, even the 2-year-old, he's yelling, he's carrying on, he's, thrashing about. And then when I stop, he's laughing and smiling. It's extraordinary. And
I think that's a good example of, as you say, the proof is in the pudding.
exactly, and that as is my favorite expression because what that says is, does it work or doesn't it work in the real world? Not theoretically, you know, but in the real world, does it work or
Yeah.
not?
Here's one. How would one deal in an interpersonal relationship with another who's defensive? Is this a reflection of the emotional armor of that person? I guess they're asking, I'm not sure if they're asking as in you dealing with that person or for themselves, but um,
Well, it's an excellent question because this relates to the very first thing I said at the beginning of my talk, and that I am going to be talking about natural science, which is a science based on observation. And this was true hundreds and hundreds of years ago, maybe thousands of years ago, but also in the present, because you can observe how the person is. Say this is a friend or somebody you just met.
Mhm.
You can observe how the person is. To arrive at a conclusion is a leap. Your observation is on solid ground.
Mhm.
This person, seems aggressive or is aggressive, or they're off-putting. But to know to conjecture why they're that way, that's totally you know it's not necessarily connected to any reality.
Yeah,
And
pretty good.
yeah, and how you relate to the person who's off-putting, that's up to you. It may be that you address it. It depends on the circumstance. And again, you want to be able to make the connection, the emotional energetic contact, but how you respond depends on the external circumstance. We'd love to all be amoeba, flowing and free flowing. But in some situations, you can't. You can't just say what's on your mind. And I use often as an example, if the person at work I won't use the vulgarity, but it's being a fill in the blank. You
You're
said, what's sorry. I was going to do a graphic gesture, but I'm not. Do you respond that way, or do you just say the guy's having a bad day, or figure out another way to handle a difficult social situation?
One person asked if I have similar experiences with patients. The short answer is yes. The one that for whatever reason is coming to my mind is like a recently retired businessman who took over the session. He was in control. He dictated where what we talked about, um, expressed all his doubts about being in therapy in the first place, wondered about, was it worth his time and the cost, and said, I could probably see some social worker who charges less or some psychologists who do this. And just my initial reaction was, You're welcome to see whoever you like, but whoever it is, hopefully they can recognize that they can't let you take over everything and be in charge of the session." And he sat there and was like, "Whoa." But for whatever reason, that was my reaction, and that was he could hear that and said, "Wait a second." Yeah, I'm pointing that out for him.
Yes.
And I guess what stands out about that is you gave a lot of wonderful examples of specific things you did for those specific patients. So it's not that you say something that sounds a little bit wild, or you are gentle or aggressive. It really depends who that patient is. When you said something about Trump, another patient may hear you talking about politics, and it's exactly the wrong thing to do.
Right.
Yeah.
I'm treating a person who's of Middle Eastern descent, and when he came in sometime shortly after October 7th, he talked about the Israelis carpet bombing, the Gazans. And I knew that that was not accurate, but I in no way took him up on that. Instead, what I focused on was his characteristic way of distancing himself from his emotion, and that was to distract himself. And he had myriad ways of distracting himself. So I didn't respond to what he said because that would have just played into his distracting himself. Sure, he had lots of feeling about what was going on. Better he should just come out with it rather than talk about it. He could talk about it. I was not going to take him up on what was true or not true. That would have just played into his major characteristic way of uh, protecting himself.
Yeah, that brings up me the idea of, is someone talking to express themselves how they express themselves, or is that getting them away from expressing themselves?
Right. And fortunately, we have the option,
Right.
even for me and maybe for you, of saying, okay, enough talk.
Yeah.
However you say that, lay down.
Yeah.
And again, that depends on the patient, where they're at, and where they happen to be in the process of treatment.
Someone asked a question about having experiences with patients who have schizophrenia. Um, is there anything you could say about that?
Yes, what I can do uh, for the schizophrenic patient uh, can um, can be astounding. Now, people when they talk about a schizophrenic person, they often have in mind the patient who's hospitalized, who's delusional, who's hallucinating, and those people can be treated on the couch. And in Dr. Coney's new book, he goes into great detail about that. But there are patients who are schizophrenic who are not delusional. They may, let's say, they're a paranoid schizophrenic, and their central uh, interaction with the world is mistrustful. So I may focus on that. Point out or ask the patient what's going on with that, and we um, uh, clearly see that his mistrust plays a part in every in almost every interaction he has, whether it's visible or not to the other person. The patient who I mentioned, who on the couch, after breathing, relived the the beatings that his mother gave him when he was 7 years old. He is a paranoid schizophrenic. On the couch, he was not decompensating. He was releasing uh, experiences that he had held back inside him that may have led or been an embodiment of his, or the source of his mistrust. But in terms of his ocular armor is significant, and he has difficulty seeing what's actually going on. He functions well enough to hold a responsible job. He even has a girlfriend of, of maybe 5 or 7 years duration, and he has a life. But I've helped him enormously by focusing on his ocular armor, by having him breathe, by working on his physical armor. And he's much more in touch with himself now than when he came to see me.
Mhm. Very good. There's a question about how do you know when a patient is ready to work on the couch in the way that we do in medical orgone therapy?
Yeah. Um, it may take years of sitting up, just talking, but at some point it becomes clear to me that what will be most helpful, if the person is ready to actually be on the couch. I may see a patient sitting up and just point out that they're not breathing, as I said a few minutes ago. And I may just say, okay, well, let's see what it looks like when you breathe. Can you do that? And I often say, can you stand it? Because people very quickly say, up, 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 and uh, they just, they stop the breathing. It's just too much for them. So seeing what the person can tolerate is crucial.
Yeah.
And I don't push my patients. That's the worst thing that a therapist can do. We see what they can tolerate, what they're ready for. Even
And I would add why they're coming to us. What are they
that's right.
hoping to achieve?
That's right. I mean, that patient who came to me depressed, whose live-in boyfriend was treating her poorly. That was 4 sessions. That was enough. That's what she came for.
Yes.
She kicked the bum out, as I said.
That was the goal. Yeah.
You're right. Well, the goal was to have her uh, uh, to see what she was doing. I didn't have to analyze her fantasies for 2 years
Right.
of what was going on. It was in the moment. What was going on? And her smile was right there. It was the most obvious, superficial uh, thing. Even despite what she was saying, that stood out. That said, hello, what's going on here?
Yes. I want to take a few more questions before we stop. There's a question about um, being clear about what we do versus other therapies that do body work, breath work. There's it almost seems like an infinite number of therapies. I wonder if you could say something about that.
Yeah, yeah. This is this is a very important question. And um, I have patients who may, in an ancillary way, have see somebody who does chiropractic or energy healing, and I see what why they're doing that and if there's any benefit to it. And again, in the context of who the patient is and where they are, it may be a good thing that they're finally doing something for themselves. But on the other hand, it could also be running away. And that's what I identify. I don't, um, I may say something very specific. I'll just say, like, as example for Rolfing, where no matter how a Rolfer or their school of treatment, no matter what they say, it's still an attack on the body. That's my understanding of how it's done. And there's no appreciation for the layering of a person's armor and their defensive structure. That's our strength. And if the person wants to do Ralphing, I look into it, and then I say, without reservation, I think this can be hurtful.
Someone mentioned your willingness to engage with a patient with humor. Could you say more about your use of humor to facilitate emotional connection?
Well, here I am chuckling at various times in my presentation. And this is me. You know, it's not that I'm deflecting, what's going on with the patient, because what I said is that, and what I've certainly come to realize is that even if it's not even, let's say, even as it's spontaneously coming out of my mouth, if I'm thinking about it later, it's absolutely right on target. What I said um, to the woman who hates Trump, you know, if she hated Biden, I'd find a way to say, something similar. So I'm not taking sides,
Mhm.
but the humor very often goes right to the heart of the matter.
Yeah.
And this is the woman, Rose, who uncharacteristically said to me, "So what do you think I should do, Dr. Chavis?" And I literally, the way I said it, it literally stumbled out of my mouth. I think you should go home and have a piece of cake. It was the most perfect thing I could say to her.
Yeah.
Yeah,
What I would add to that patient's question is, um, how you make a connection with a patient with that you're seeing may be different than how I connect with a patient that I'm seeing, because we're two different individuals, and what works for us to connect with someone could be different.
that's right. Of course,
Yeah.
of course. Again, this is not a, a cookbook therapy.
Right. Right.
And again, that's where emotional energetic contact is essential because that, as I said, it helps you to see, perceive, and feel where the patient is at the moment.
Yeah.
And that's crucial because then you can decide in your own way, in my own way, in your own way, what you feel is best and right for the patient at that very moment. This is who I am. And I've had enough of my own medical orgone therapy to be very much like, I'm not saying I am the amoeba, but I'm very much like the amoeba, free flowing. And yes, I have the capacity to tolerate what is going on in the moment, my own feeling or the patient's feeling, and to be present. And that includes being able to be funny or not. You know, with this woman who hates Trump, I'm not taking sides, but the fact that she gets so furious and she uses the F word and the S word, and to see this 85-year-old who grew up being a good girl and having to be a good girl, to be able to just let it fly out.
Many of the audience have mentioned feeling moved by you talking about your patient. So I think um, even through a Zoom connection, through a computer screen, it's amazing, a connection I think we can have.
Yes, yes,
Yeah.
yes.
Dr. Chavis, anything else you'd like to say to the audience before we stop?
Well, I want to thank everyone for participating, for joining the webinar, and just experiencing, what I had to say, and and learning and enjoying it as well, enjoying what I had to say because I love my work and it's real. It's just it is.
It shows. Thank you very much, Dr. Chavis.
You're welcome.
And a special thank you to the donors of the ACO who make our work possible. I hope you'll check out the Journal of Orgonomy that's now on Substack, and also our podcast, the A Different Kind of Psychiatry podcast. Our next webinar will be next month on Saturday, April 12th at 1 p.m. Dr. Susan Marcel will be presenting Suicide Prevention, Relationships Matter. Hope to see you there.